we talked just a little bit about like the tension that this medical diagnosis brings because like after question one and two, there's a little less urgency, and then when they have the diagnosis of active TB, it adds like a competing interest of like timing to get this patient connected to care that's actually fairly intense. And there's now a public health aspect to this case. And so navigating that situation with the complexity of like the patient probably not understanding much about the American healthcare system, having a history of trauma, um, just makes it so difficult. And so we kind of reflected in that, you know, it's not that surprising that this was the outcome because of these challenges. And then the question is like, what do we do to reduce harm and take care of the patient?
Yeah, thank you, Jason. Yeah, exactly. It's not surprising. You arrive in Seattle, and then shortly after, you're told, we're going to keep you in the hospital because you have this serious illness, which is well known to be contagious and a public health hazard. And the implications of that alone and the fear that are associated with that alone, pretty scary. And so for him to say, no way, I'm not staying here. I came here to be free and to live my life and to establish a new life. That's pretty reasonable. Yeah. All right. Thank you for your reflections on that case. I think I share a lot of those reflections as well. And in that moment, I had the feeling of, we need to do everything we can to meet this patient where they are. And ultimately, he had a good outcome. He um, continued on RIPE as an outpatient. He's currently taking it right now, but we actually had to pause his therapy because he developed neutropenia from his rifabutin and then LFT elevation related to one of the medications. But he's well connected with ID and with ophthalmology and with myself, and so we're making some progress. All right, so let's move on to case two.
So this is one of my patients from the International Medicine Clinic, and I really welcome you to type into the chat any questions that arose for your group or revelations or ideas. I think, or to speak aloud if you have something you want to share. I think one of the things I struggled with in my care for her is this feeling of her deep well of trauma and her ongoing um, PTSD and some major depression and um, her priority, which was I need to get citizenship. I have family relying on me back home that I want to go back and check on. Um, and I'm about to hit my 5 years, and I have not been able, with all of the things in my way, to learn English or civics in order to pass those tests in order to become a citizen. And the her number one priority was getting that waiver, which we as physicians can do. Um, and so it was really challenging. Thoughts from the group, either in the chat or out loud, about some of the thoughts you had in your group or the discussion in your group? The first case got everyone excited, so it's hard to get to the second case or the third case. Thanks for that, Magna. Um, some of the things that come up is I think just awareness of resources. You are not alone in caring for folks in these situations. You, of course, always have your attending and, clinic social workers and patient social workers. There are wonderful community groups, volunteer agencies that help with this, REWA, Refugee Women's Alliance, and East African Community Services. Um, and um, the N648 form, if someone asks for it, or usually they'll just bring it with them, or they'll say, I haven't been able to learn English. There's some really helpful tips on Ethnomed, which is one of our homegrown websites about culturally appropriate care. If you find yourself in the situation of needing to fill one out, and you should always do it with an attending because I think you have to be fully licensed in order to co-sign it with your patient who's applying. And it's just a series of questions about whether or not someone is able to read English or learn civics. And unfortunately, never having gone to school, being illiterate in all languages is not a qualifying condition. For some of our patients, it's easy. This person has dementia. You know, they we've got brain scans where we have a diagnosis of Alzheimer's. For others, it's a little more challenging. Traumatic brain injury, you can make an argument, um, and there is case law and the ability for us to say that um, mental illness, such as PTSD, severe depression, um, change your ability to concentrate and learn, and lay down new memories. And so that is an argument we're able to make for an N648. And so that is the argument I made for her, while also talking to her about the Harborview Center for Assault and Trauma, counseling, medications, resources that she might be interested in. She was grateful to hear about those, had no desire to follow through on those right now, but at least knows about them. And I will continue to check in. And this was a patient I saw maybe 9 months ago with this concern. She has subsequently gotten her citizenship, gone back to visit her family, and had came back with the biggest smile I have ever seen. And so she got a huge amount of joy and healing from getting citizenship and being able to leave the country for a little bit and reconnect with the people she loves. Um, and with that, I'll pass it on to
Yeah,
case three, Shri. People
yeah.
feel free to add thoughts in the chat or other thoughts.
Yeah, and I wonder just on case two, I wonder about this dichotomy, a patient comes to clinic and they are requesting very specific assistance. And I think we've all experienced this, help with paperwork. And as you start to kind of unravel it, you realize that maybe there's more to it, and maybe there's more that I could offer this person outside of just filling out a form. And I think that's a really difficult situation to navigate. So I want to acknowledge that. And if people have thoughts on that, as we're going to case three, feel free to share them. Uh,
And I would throw out that sometimes those forms or writing those little letters are a real way to build trust and therapeutic partnership. And sometimes the questions we ask as part of those forms or the ways in which we connect with people can be pretty powerful in terms of understanding our patients better.
yeah. All righty. And then our last case, and maybe some of you didn't have a chance to get to this one, but I'll summarize it. So this is a 65-year-old man who arrived to the United States via refugee resettlement. He left Afghanistan, was in a refugee camp in Qatar, and then subsequently came to the United States and was resettled in Seattle, um, and was really seeing you due to mobility concerns, having difficulty walking, and describes to you a history of torture and spinal cord injury as a result, but then also another spinal cord injury unrelated to torture. Um, and now is trying to navigate his social needs in the United States, which is a complex thing to navigate. Um, and is really looking to you for assistance. What thoughts did people have as they were going through this case? Any other questions that came up, uh, or feelings as they were thinking about the history that he shared with you about his torture? I'd love to hear your thoughts, and then we can dive into some of these specific questions as well.
Shri, how about you walk through some of the learning points you got from this case, since it sounds like people may not have made it to it in the
Yeah,
description.
yeah, totally. So I think in regards to the question number two, I'll just share with you my thoughts. Um, he was pretty willing in the beginning to start talking about his experiences. And I think that there was an opportunity there to, potentially dive more deeply into what exactly happened. And I'll admit, I was curious. When people start telling their story, uh, it's it can sometimes be hard for us to not be entranced by the story. And I definitely felt that. I wanted to know more. It was something that was tragic that he experienced, and I wanted to know the details. And yet, I was also tasked with addressing his concerns and the reasons why he was here. And so ultimately what we decided on doing was I said, I want to hear more about this. I want to allow you to share your story. But I don't want to put you on the spot right now. So maybe we can talk about it at the next visit. And I think that that felt really good because it allowed him to, either say, no, I don't want to talk, or I don't want to talk about this right now, but also allowed him to potentially prepare for a deeper discussion of it, and anticipate that at the next visit. So we ended up focusing on his mobility. And I think that, the big thing that I felt was this quote, which I included at the end of the case, which is, "Doctor, please help me. You're the only one that can find a solution for me." And he said this to me as he was describing his mobility concerns. And I'm sure you all have heard this before. Um, this kind of plea for help, this desperation, and the patient in front of you feeling like you're the one that can fix it all. It's kind of a high pressure situation, and it feels like a lot to handle. And I think in this moment I felt that. And at the same time, this is a patient that is surrounded by resources. He came by a refugee resettlement. He has an organization that's helping him with resettlement. He has a case manager. We have a clinic social worker. He has his family. His wife is here with him. And to be able to pivot and say, you know, we really need to find the people that can help you. And that person is not just me. There are so many other resources, and I am here to help you find out who those people are and to walk you through it, um, and make sure that they hear your side of the story. Ultimately, that's what we did, in the room, sent an email to his case manager and said, "Hey, this is a real issue. This is a gentleman who can't walk, and he has so many stairs in his apartment and keeps falling. What can we do to find him a different apartment that has either no stairs or less stairs?" And it took some time, but a month later, he's in a new apartment. And so, um, yeah, this is something that's going to happen, and it's not going to necessarily be in the setting of a refugee, but it'll happen with another patient of yours who has a different social need. And feeling and moving away from feeling like you're alone and trying to find the people you can lean on is the thing I'm hoping you'll take away from this case.
There was also a nice note in the chat, opening with asking permission is always so helpful, especially when it's a sensitive topic, um, and recognizing that it can be difficult to talk about these experiences. Thank you, Astrid. It's deeply wise. Shri, I'm noticing the time. I think we're at 11:30. Thank you, everyone, for sticking with us through all kinds of AV adventures and speaking so thoughtfully about these topics. They are near and dear to all of our hearts, and so we've included our contact info if you ever want to reach out. Um, and go forth and do good work and stamp out disease and bring joy and love to all around you. We're so glad to get to work with you.
I echo that. It's nice to see everyone. Enjoy the rest of your afternoon.